Welcome to Inside Aesthetics, the world's leading podcast for aesthetic medical practitioners and injectors. I'm Dr. Jake Sloane, a Sydney-based doctor, speaker and trainer with over 17 years of experience.
And I'm David Segal, an aesthetic business entrepreneur and mentor with over 20 years of experience in our industry. Our podcast is aimed at medical professionals only, and we share industry insights from leading experts. Our podcasts are general in nature and should not be used by prospective patients for any medical advice or treatment decision-making. All patients should have a consultation with a medical professional and have a bespoke consultation before proceeding with any treatment.
You can also subscribe to our Patreon for on-demand educational content, videos, business coaching, and networking with over 350 other injectors from around the world.
It's that time again, Jake. It's everyone's favourite mini-series, What's Trending in Aesthetics.
I think it is. I think people quite like it.
Yeah.
It's a little less intense, a little bit more general, a little bit more relevant to what we do every day.
Looking at what's going on, a little bit of gossip.
Yeah. I've just got back from holiday, so excuse me if I'm jet-lagged and brain-fogged.
Yes.
But nice to see you again.
Yeah, you too. You chose to go to Dubai in the hottest time of the year.
It was great.
900 degrees.
We love it. Look, we obviously stayed out of the heat from about 12 till 2 or 3. The kids were having a bit of screen time and downtime, but it's a lot of fun.
Yeah, nice. You gone for 12 days, was it?
Yeah, about 12 nights.
Where did you stay?
We stayed at Atlantis the Royal, so next door to where you just stayed.
Right.
We've just got back from
Yeah, we almost high-fived on the way through.
And why are you hobbling around on crutches? Tell everyone about that.
So, I have some arthritis in my ankles from injuries when I was younger. And on my way back to Sydney from Europe, we stopped over in Dubai and I got some stem cell treatments in my ankle. So,
well, first of all, what did you do to your ankle as a kid?
Oh, just sporting injuries, reconstructions.
Like what? Did you turn your ankle? Did you break your leg?
Yeah, just stuff on bikes. So fractures, just lots of just punishment over the years,
right?
From silly things. So, yeah. Most of the time I'm fine, but sometimes in super cold weather, or if I've had like a day of hiking, doing like 20 or 30,000 steps, it gets a bit sore the next day. So, understand the body doesn't normally get better as we get older. So the whole idea was to try and get some stem cells in there to improve the area, maybe reduce some of the arthritis, help with some of the scar tissue, build new cartilage. So I got umbilical stem cells. So I got, I think it was like 40 million stem cells in each ankle. So it was done by an orthopedic surgeon from Germany who now lives in Dubai.
Right. And
they've got this multidisciplinary clinic that there's a dermatologist on site as well. There's a few other sort of specialties that use it for different things. But this guy treats, like I think he treated the guy that plays Thor, what's his name? Chris Hemsworth. Oh, yeah. I think him and his team treated his shoulder.
Right.
And lots of other like high profile athletes. I'm not a high profile athlete, so hopefully they can help me. Yeah. So look, it's not guaranteed, but there's a lot of promising results coming from stem cell treatments. You hear a lot of people that have gone and had, horrific sporting injuries that are going over there and sort of able to play again and expanding the length of people's professional sporting careers. So it's been a bit rough. Like the first 3 days or 4 days, I couldn't walk. I was almost like I'd fallen out of a wheelchair. I couldn't actually walk. The swelling was so intense because of the scar tissue reaction.
Right.
So I was sort of like, crawling around. It was quite awful, to be honest.
Yourself a wheelchair.
Yeah. And the only wheelchair was like for a morbidly obese sized person. So I'm a small dude and like in this massive chair getting wheeled around. It was quite full on. But the good thing was, express through the airport in the wheelchair.
Yeah.
Oh, it was very
first class.
Yeah, it was great. So now I'm still sort of limping around a little bit. I'm just trying to keep the weight off it while it heals up. So it could be up to 6 weeks before I'm back to baseline. And then I should start to notice improvements, if there are going to be good significant improvements within sort of 3 to 6 months, depending. Okay. So yeah, the theory is these umbilical stem cells can essentially become any cell. So they're blanks, basically.
Pluripotent, as we say.
That's the one. So cartilage, they can, older scar tissue, as you point out, is more difficult to deal with, but it can help soften it, improve blood flow, because that's part of the problem as well, that the scar tissue impedes blood flow and can sort of make it more prone to inflammation. So I might need to get more treatments, and hopefully if I get a good result from this, in a year's time or so, if I have to get subsequent treatments, it will be less intense because it will have done a lot of work to repair the area.
So how do they inject it under imaging? Or?
No, basically he just goes basically directly into the joint, into the meat of the joint of the ankle.
Jesus Christ!
Yeah,
so this is the main joint under your shin bone. You've got your ankle.
No, basically straight into, people can't see, but like straight into here.
Yeah,
with a needle about that.
That's your main joint.
Yeah.
Okay, well, good luck with that.
It didn't actually hurt at the time. I was like, oh, this is no problem. And then like it just started getting, like my foot looked like Shrek foot. Like
Do you know how much was injected in?
It was also mixed with hyaluronic acid.
Oh yeah, so how much volume?
It was about, I think it was about 6 mils.
Okay, I mean, 6 mils in what is a smallish joint is going to cause a bit of a...
Yeah, 6 mils. And it was 40 million, I think, in each ankle.
Right, okay.
So,
are these a named brand stem cells?
Or... they give you all the information of like what laboratory it came from and the quality and all that kind of stuff.
Can you buy them off the shelf?
No. They make them specifically up for the patients. And the wherever they make them gets delivered cold delivery to the clinic, and they're there for you. So you have to sort of get them ahead of time.
Okay.
Yeah. So lots of pain, very expensive, but we'll see. We'll see how we go.
Good luck with that.
Yeah, thank you. That's my story.
Podcast news.
Lots happening. Oh my gosh.
Yeah. You guys may have noticed that the podcast has been, we've been on a break of sorts. So we've been putting out some of our mini series with Fresh Clinics. So yesterday, Chapter 3 came out.
All about marketing, yeah.
Yeah, all about branding and marketing and what people probably aren't doing.
Yeah.
So we have been putting out content, but yes, it's been a little bit staccato and there's lots going on in the background. So should we sort of share what we're trying to do, what's going on?
Yeah, well, we've reached this point, I guess, 6.5 years later, we've just sort of been doing this on our own, sort of piecing it all together, scrambling every week to get content out. And neither you or I are podcast people in terms of the back end production and editing and all the socials that need to go along with it. And we've got our day jobs as well. So we've made the decision to get some serious professional help. So, and this kind of came off the back of the stuff that we did with Fresh, like looking at what like good quality production and getting like a solid team behind you and a proper workflow. So we are going into podcast redesign iteration. I think it's number 4. I think it is now.
Yeah. So this room where we record, it's David's second bedroom, and this room's changed 3 or 4 times. And each time it's been a bit better than what we started with, but it's never quite been right.
Yes.
And years ago, you guys may have remembered, we sort of threatened to be on YouTube every week. There were videos every week. It just never kind of got there. We worked with 3 or 4 different editors. It just didn't work.
Yeah.
It was either non-sustainable, not good enough, or too expensive.
Yeah. And well, now we've got people that are doing podcast production full time. Like 6.5 years ago, there weren't the people around that we're looking to work with today. So the industry, or the podcast industry, is kind of developed, and now there's people that can offer professional help. So as you said, full video. Hopefully we'll be having our episodes in full video, like on Spotify and Apple. You can do Apple as well, right?
No, YouTube.
Okay, fine. All of our equipment's fine, but we'll be changing away from Zoom to a more, I think that's been the limiting factor in terms of the quality of the images or the video, has just been that Zoom sort of down regulates.
It's super frustrating. We're looking at our images right now. They're fantastic. We've got a monitor in front of us, but when that goes onto, the socials, it looks grainy, it looks pixelated. It just looks rubbish.
Garbage.
So hopefully this will all improve. And we're also going to be working with a new strategist stroke. I don't know what you call
a podcast manager.
Yeah, sort of like a podcast manager. We'll hopefully formally introduce her one day once we get the ball rolling. But we're going to be just trying to work on a more global, long-term strategy. As you would have realized, this is one of many of our mini series, and we're just going to try and tidy up some of our production and content just to make it a little bit more streamlined.
Yeah. So stay tuned. So there's been a lot of stuff happening in the background, and then the rest of the year is looking pretty nuts as well, because we've got 2 big conferences that we're doing in September, which is, feels like I just got off a plane. We'll be getting back on one again.
I got off a plane yesterday, and then I booked 3 flights yesterday for us. So spending a lot of money in flights. But we obviously did a competition with CAMA, who are the Canadian Aesthetic Medical Association, and we'll be going to the big conference called the Canadian Aesthetic Expo. So that is in September. And then after that was already organized, we were invited very graciously to another huge conference called ICCE in Cairo, Egypt.
Yeah, and that came through a good friend, Dr. Felix Bertram, who sort of said, you got to get these guys over there.
Yeah.
While I was overseas, we started organizing it.
Yeah. So we will very soon be announcing a big competition to get one person there with us with a special golden ticket, as we call it.
Yeah.
But that will be happening the week before the Canadian conference.
Yeah.
So there's a lot going on.
Yeah. And this event's massive. I mean, headliners, Arthur Swift, Sebastian Cotofana. I think there's like 10,000 people coming. I think it's the biggest event in the Middle East. And
in the world. Well, I would guess
We'd rival
numbers-wise, that's getting to rival, not quite MCAS, but it's probably the third biggest one that I can think of.
Yeah, right. And so some big names there. We'll be there. We're doing some things a little bit differently. So we'll be doing some live podcasts. They're building a little glass studio for us to do some interesting live content. So it's going to be cool.
And I guess if you're listening to this and you happen to be in Cairo or Middle East and you want to have a chat and record with us, we're open-minded.
Yeah.
Reach out. Let us know. We'll see what we can organize with you. But we'd love to record some different content, meet totally different practitioners who we've never spoken to before.
Yeah.
So that's part of our strategy as well, is not just to go and have a nice jolly in front of the pyramids, but to actually change our content, to mix it up and do something a little bit different.
Yeah, and some of the stuff we'll be doing as well will be quite interactive. So, part of the plan with where we'll be recording this is that we'll be sort of talking to the KOLs that are going to be there, asking them questions, but there'll be opportunities for people attending to participate, listen live on their phones, submit questions, all these kinds of things. So it's going to start changing the way these conversations happen and offering maybe a different way to get to know these KOLs or to explore a topic rather than just a one-way sort of delivery of information. I think it's kind of exciting and different.
Yeah, we're trying to keep things a little bit fresh and a little bit different after 300 episodes.
Yeah,
we could carry on. I know that you guys enjoy injector diaries and some of the sort of common themes that we do, but we always want to try and keep it fresh and real.
Yeah, exactly. So what's trending, Jack?
Well, when I was away, just a couple of things that sort of struck me that people were talking about or Instagram was going nuts about. We'll start with Steve Harris's post, our friend Dr. Steve Harris from the UK. He's not shy to push the needle in and see what happens.
Not shy of controversy, yeah.
No, but to be fair to Steve, whether you love him or hate his content, I'm sure most people sort of enjoy, at least, maybe they don't agree with everything, but they like the fact that it's thought-provoking and debate-provoking, but he's never changed his tune. He's always been very, very, very much of the mindset that, we should do no harm, we should be making people look normal, not like aliens, and all the rest of it. And his post was quite interesting. It was about, what do we do when we're confronted with the scenario where a friend or an injector colleague starts to look unusual, overly augmented, overdone, overfilled, whatever you want to call it. It's a dilemma that, it's not new. We've sort of, joked about, but I guess it's also true that if I go to a conference and see them in the crowd, see these people, and, it's not for me to say that's right or wrong, but it is a dilemma.
Mm-hmm. So, he did an interesting post yesterday that we both saw, which was effectively two images side by side, one of someone that looks normal, in inverted commas, someone that maybe gets treatments done, but you wouldn't probably know. They just look nice, fresh, healthy. And immediately adjacent to that is someone that's gotten high on their own supply. Their lips are arriving 5 minutes before they do, overly augmented cheeks, quite unusual looking, especially for someone that's not, I think people like you and I that are in the industry, we're used to seeing perhaps more over augmented results just because we're in the space. But I think even more shocking to someone that's a prospective patient that walks into your clinic. And we had sort of similar issues when I owned my clinics with certain members of the team, especially on the front desk, that would just go way over the top. And then, how do you have these conversations? But effectively the image was depicting these two different types of people and asking the audience to ask themselves the question, if there was a injector that you were going to see that would give the same advice but had either presented as option A or option B, which one would you go to? Which one would you trust?
Yeah.
And it was quite interesting.
I mean, we see this. Sydney's a great example. Depends if you're east or the west, right?
Mm-hmm.
I mean, that's a joke, but it's also, I think stereotypes have a truth behind them.
Yeah, of course.
And, some people aspire to either of those looks.
Yeah.
So, I mean, from a layperson's perspective, do you think it's ethically right that me as an injector says you're overdone or you're not overdone?
So paint the scenario for me. So just let's because I think nuance is important.
Well, let's use your example. You've got a new receptionist, or not new because you would have known what they look like in the interview, but they've had some treatment by your injector, and you come to the office one day and suddenly you're like, oh, she looks a bit different.
Yeah.
And that's your front of house.
Mm-hmm. Yeah.
Do you just say nothing? Or as the owner of that clinic, do you have a quiet word with the receptionist, the injector, both, neither?
Yeah.
It's tricky.
Yeah, it is. And that's when people start to think about what they put in their policy and procedure manuals around presentation, like face tattoos, hand tattoos, neck tattoos, too much makeup, overly augmented appearance. I mean, you can start to put these things in. So I think, not to dodge your question, but I think you can potentially overcome some of these issues by being very honest and direct with what your expectations are and what's acceptable and what's not.
Yeah.
When you have someone join your business. I think that these discussions need to be had. I think it just depends on how it's delivered.
Yeah.
I think nuance and tact are very important. I think a lot of the time people don't want to look unusual. I think that either they're in a circle of friends who all have a certain aesthetic, and then it's kind of like this, you just become the average of people that you spend the most time with. And if you're hanging around people that are overly augmented, then perhaps some of that rubs off on you and it starts to get normalized in your own mind.
Yeah.
And then we also have the issue of like perception drift, where you don't realize that you're starting to look unusual. There's a psychological kind of element to people feeling they need to get more done all the time because it makes them feel good about themselves. So it's not actually the result aesthetically, it's the process of going to have the treatment done and actually thinking that, okay, I'm looking younger, I'm looking better.
Yeah.
So there's so many aspects to this, but I think ignoring, especially if it's someone in your business, I think you need to bring it up and say, hey, like, you are starting to look overly augmented. This is not the look, that we want for our clinic. It potentially could make people not want to come into the clinic. And so, we need to address this. I think it needs to be addressed. I think it needs to be done delicately, respectfully. Yeah. You don't want to start calling people names or, doing it abruptly in front of other people. I think it's a quiet conversation, with you, and maybe if you've got a manager, having a third party there for these delicate conversations, especially for me as like a male, like a female staff member, it's always good to have a third person there.
Yeah.
And I think it's just being delicate around it. And then, I had to get to a point where we had to start banning people from treatments to say, like, you actually can't get any more treatment done at the clinic because you're starting to look weird and it's freaking our patients out, in a nice way, not saying it in those words. And then the other thing I forgot to mention as well is that, we know now that these fillers sort of tend to become more exaggerated over time. So what initially in the first few days looked fine, as they accumulate water over the years, what was, this, and I go back and think about all the times people said, they do Instagram posts of this is just a teaspoon of filler without the nuance of, well, this thing carries 1,000 times its weight in water or whatever it is. So it was kind of a bit misleading, I think, in some of the way that was done.
Yeah, I've been guilty of that, but I know the science of the hyaluronic acid and exactly what you just said, but don't know if it actually looks 1,000 times bigger. Well, I'm sure that's not true.
Let's call it 10 times bigger. Let's remove 2 zeros.
I don't even know if that's true. I think the science of what we understand hyaluronic acid is supposed to do versus what it does, something's not adding up.
Yeah.
And you get the opposite effect where, definitely had patients where you could do mil after mil in their lip and it's almost like nothing happened.
Yeah.
So, it's not a black and white science.
No, but this comes down to being an experienced injector that understands when not to, what this potentially is going to look like in a period of time. So I guess to answer the question, I think you need to address it. And if it's a friend to friend thing, if it's not someone that's working for you, I think you owe it to your friend to be honest with them and say, look, I love you. I care about you. Just want to let you know that you're starting to look a little bit unusual. You're a really attractive person, but this is starting to detract from your appearance. If that's what you're going for, that's cool. But I feel like I wouldn't be a good friend. Sometimes friends need to tell you sometimes uncomfortable truths.
It's almost like if you've got a bogey hanging out your nose, you want a good friend to tell you, right? It's kind of the same analogy. Yeah. But self-inflicted, I guess.
Yeah.
I mean,
what do you think?
Well, I agree with everything. I guess from your perspective, it would be even trickier because you're not an injector.
Yeah.
So if you had to have that chat with your staff, and I completely agree that as maybe an older male speaking to younger females, it could come across like a personal critique or even bullying rather than, sort of constructive feedback.
Yeah.
So that would have to be very delicate. But as an injector, and let's say you were my injector colleague, and I thought you'd kind of overcooked it or things aren't looking right, sure, I would definitely bring it up. I'm not going to do it in front of people. I'm not going to do it in a way that's going to make you feel vulnerable or silly, but I'll try and be constructive.
Yeah.
But it's awkward because ultimately you're saying it doesn't look good.
Yeah. And then there's the other.
And I would want it to me, by the way, as well.
Yeah.
If someone said, hey, your jawline looked good a few years ago. Now you look like Desperate Dan. I want to know.
Who's Desperate Dan?
Oh, God. Okay, Desperate Dan is a character from the Beano, which is a very old British comic. So sorry if that...
right.
If that analogy doesn't work.
I was going to say Quagmire from Family Guy.
Quagmire. Okay, whoever. Someone with a massively over-augmented jaw. But, I kind of want to know.
Yeah.
Yeah. And you're always going to feel a little bit defensive when someone says something that you think was good and now someone's saying it's bad.
Yeah.
But I'd rather know than not know.
Yeah. And then there's the other issue of, well, even if you've decided, hey, I need to dissolve this, there's the whole fear around dissolving. Am I going to overcorrect? What am I going to look like when all this filler's gone?
Yeah.
We had Dr. Daniel Ezra on about a year ago talking about the case for maybe you shouldn't be dissolving. Maybe you actually, maybe it's not a good idea. And then I guess there might be some people that understand that they don't look ideal, but are worried about the fact that what are they going to look like once they have all that product dissolved?
Yeah.
Is it too confronting? And then, what Dr. Ezra said, like, is there potentially some medical reasons why you shouldn't dissolve?
Yeah, look, the longer you do this, so if you've got 10 years or however many years of filler in your face, that argument becomes more and more pertinent, I think.
Mm-hmm.
But, if it's a case of younger patient, just lips are too big, cheeks are too sharp, that can easily be dissolved. And I think you go back to your baseline. It's a tricky one.
Yeah. Well, I met lots of injectors that are self-dissolving now, lots and lots and lots. So it's something that everyone's recognizing as an issue.
I mean, going back to your or Steve's example in his post where someone looks inverted commas normal, someone looks more augmented in their injectors. Do you think that, I mean, I can speak from my experience. My patients, they're all similar demographic. They're what we call positive agers. They tend to want to have a more conservative look. And one of the first things that comes out of their mouth before I've even said anything is, I don't want to look like so-and-so. It's the biggest barrier. I want to look normal, not weird.
Yeah.
So patients presumably self-select either through seeing before and afters or getting some sort of idea of your work or recommendation. But oppositely, if someone looks augmented or treated, some people self-select for that as well.
I think it's a major business misstep being an overly augmented injector, and especially if you're trying to build your practice. I mean, the people that want that overly augmented look, and as we said, like, it's a free country, you should be able to do that if that's what you want. But understand that if you present that way, you're effectively alienating the majority of people that want to undergo these treatments. There's only a small segment of the market that are going for that look.
Yeah.
So how many patients, this comes back to, your marketing strategy.
Yeah.
Who are your target demographic patients that you want within your clinic? What type of patients do you want in your door? If you want the positive ages, people, with more disposable income from sort of 35 to 60, are you going to get those patients if you look like that? I don't know. Probably not.
I mean, you and I know at least several injectors who run their business like that without mentioning any names. So that's fine. And that's okay. Like, I'm not sort of here to judge. If it works for you and your patient's happy, what difference does it make to me? But I think that trend that we saw probably 2016, 17 was the peak of lip filler in Sydney. I would have guessed, having been an injector in that phase.
Yeah.
And, you were running clinics where it was like many injectors' days were just lips.
Yeah.
It was just,
cool.
I mean,
Laser Clinics Australia had the Lips to Love.
Yeah.
$3.99 or whatever. I can't remember. It's been so long now. It was
$3.89.
$3.89 Lips to Love, and it was just plastered everywhere.
Yes, and it became a thing, a self-fulfilling prophecy. And there were clinics who literally just had hordes of mainly younger girls just queuing up just for lips. It's all they did. And kudos to them. They're running successful businesses, but it created a look that we now look back on and go, probably wasn't in the best interest of the patient.
Yeah.
But it worked.
Well, financially it did, yeah.
Well, yeah, exactly. So I just think that maybe that model that presumably is still going on somewhere is going to be less and less likely to work.
Yeah.
Because of the market demand.
Well, the market's maturing, not just business-wise, but in terms of patients in terms of what they want for themselves, for their, aesthetic appearance, what kind of businesses injectors want to run. The more filler you put in someone's face, they start to become, more difficult to manage. Dissolving's an issue. Like, it starts to become a more high-risk profile patient, I would think.
Yeah. And this is going to sound judgy, and probably some people are going to hate me, but it's a very basic way of injecting. You want a lip? We'll do your lip. We won't do the chin. We won't sort of make it look holistic. We won't look at your profile. Same for the cheeks. We'll just do some cheeks. Fine. Can get your cheeks today. But it's not a very intelligent way of injecting.
Yeah. And as you said, I think it's the road that some injectors that are less experienced sort of go down initially until they start to find their way and start to understand the nuance and facial harmony and balance. And as you said, it's a very difficult thing to critique because you're sort of at this intersection between like art and fashion and medical science.
Yeah.
What's your responsibility as a practitioner versus what's someone's right to express themselves in a certain way aesthetically. So very delicate. But I mean, where do you think it's going? I mean, what do you sort of see as the upshot of all of these questions being asked, people dissolving? Do you think that it's just going to continue along this way of just less augmented looks? Do you think that these are...
I just think we are more skilled and understand the face and filiology and what beauty is better. Yeah. I mean, I still have an issue with, not any particular company, but most of the companies will teach a completely new injector how to do cheeks and lips on day one.
Yeah.
I do have an issue with that. Not per se because it's bad, but because it teaches the principle that that's what you should do on day one.
Yeah.
Without any nuance or understanding of, sort of the wider implications. And it leads to what we just discussed. It leads to, well, if I can do it once, I'll do it again and again and again, because that's my skill set. So, I think as an injector, it's we need to understand what we're doing with this product.
Yeah.
Because if you just keep on doing the same thing over and over, which you can do, and people will pay you for it, people will look less and less normal.
And yeah, as you said, allowing green or inexperienced injectors to sort of run free with these products without understanding their craft at a deep enough level yet is an issue. Like I've said many times, and recently, if I was to start a clinic today from scratch and I had to hire people, if I had a new injector coming into my business, they would only focus on 3 things for the first 1 to 2 years.
Yeah.
Their consult. And that consult goes much deeper than, going through all the questions, doing a facial assessment, taking photos. That's just like the mechanics of what you actually need to do, but how to communicate properly, how to build rapport. Facial anatomy and toxin. That's it. Yeah. Focus on those 3 things.
No filler for 6 months.
At least.
Yeah.
I mean, how can you build up enough skill within that time to see enough faces, enough different anatomy, different aesthetic goals, how to do a great consult? Like, I think you've got your hands full learning all those 3 things.
Well, flipping it the other way, it seems insane that an injector who can't do all of that, but can just do lips and cheeks, is allowed to do that.
Yeah.
It seems mental when you think about it. When you say it out loud, it's like, oh, but they can't do chin, jawline, temple, under eye, good toxin, but they can do those other things.
Yeah.
It seems a bit crazy.
When you were learning to drive a car, they don't just like hand you the keys and say, here's a V8 turbo that you can just drive. You've got to go through your learning process first. You have to have someone with you. You've got all these restrictions on you in terms of how fast you can drive and what sort of car you can buy for the first period of time before you're allowed to have a fully unrestricted license.
Yeah.
I always relate it back to cars because I'm a dude, but I mean, I think it's a kind of similar analogy. You need to just sort of stage people's, and what I've experienced, what I've had some conversations recently, and I think, I'm not sure whether I mentioned this in the previous podcast, but injectors that have got so business owners have got injectors working in their practice and sending a patient to one of their injectors for a treatment, and that injector not doing the filler or talking people out of it. And it's because they don't feel confident, but they've just sort of been thrown this task. So it's almost like they've been set up to fail, and they're too scared to say anything to their boss because they don't want to seem silly, or they're slow learners, or they're not going to be able to keep their job. And I think we're starting to realize, like, this is a really deep craft that takes time to learn. Like, don't force people to try and take on too much too quickly. And this is what leads to all of this negative PR, the horror stories, people feeling like they've been upsold to because people haven't got their consult down properly. They haven't communicated. The patients don't understand. They've potentially done treatments they shouldn't have done. Complications happen. I think a lot of this is coming down to the fact we're just trying to push people too quickly to learn an art form and a discipline that takes many years to get good at.
Yeah, I totally agree. And I think we've been singing this song on the podcast for a while now.
Yeah.
I don't know how we solve it. I don't know who's going to create the syllabus. I don't know who's going to regulate it, but the quality could be a lot better.
Mm-hmm.
You know, it really could.
Yeah, well, the market's going to demand that as the patients become more sophisticated.
I mean, if you wouldn't send your mum or girlfriend to many clinics because of what you perceive as being basic injecting, that can't be right that the public don't know that. Mm-hmm. They don't have that insight.
Mm-hmm. Yeah.
So,
yeah. This is the challenge, isn't it? I mean, how do you sort of play catch up with an industry that's sort of gotten away from itself?
Yeah.
I think.
So so you're the business owner again. What do you do when your injector, who inverted commas looked normal, starts to not? Because, you know, it's one thing for a patient to come in overly augmented and you're in the dilemma of what do you say to them. It's quite another when your provider of your own treatments starts to look like that.
Yeah.
So again, I mean, yes, you're the male sort of business owner, but just as a generality, what do we do with that problem?
I think it's just, as I said, important to have honest conversations delicately as soon as they start to present themselves as an issue. Let these people know, hey, you're starting to look a little bit overdone. This is not in line with our policies and procedures manual in terms of how we need people to appear at work, just like, as I said, with like tattoos on the face or, you know, your uniform, makeup, all those things. You have a right as a business owner to request how people appear at work. I think it's nipping it in the bud as soon as it starts to become an issue and letting people know. And it may end up being that they might not be the right person for your business. If they take offense to that or refuse to adhere to what you're requesting, then perhaps they're not the right people for your business.
It's super tricky, isn't it? Because how are you going to apply your lips are good or overdone? How are you going to apply that as in a context?
Yeah, well, it's hard to quantify, isn't it? Because, you know, bigger lips on someone's face might look okay because they've got bigger features, they're a bigger person. Yeah. Whereas someone that's, you know, quite slight and has a fine bone structure, maybe it's going to look really unusual on them.
Yeah.
So, I don't know if there's an easy answer other than just, you know, making it clear what the expectations are and having honest conversations with people delicately and seeing where the chips fall. But it may end up being that those people just aren't right for your business.
Yeah. I mean, silly example, but I think it's a relevant example. You've just been to Dubai. You would have seen, or maybe you didn't because you're crawling around on the floor in your wheelchair, but you know, the look over there, and when I say over there, this is a real stereotype because it's such a mishmash of expats and locals and the big Russian population now and so on. But a lot of the work that I saw isn't great. I'm just going to put that, and especially when it comes to lips.
Were you critiquing people at the pool?
Maybe in my head. You know, I wasn't going to go up to them and offer them my professional courtesy in the pool. But, you know, I guess what I'm saying is you have microclimates of what is a trend or a fashion.
Yeah.
And it's seen as totally normal. Yeah. Everyone aspires to it. Your social circle presumably has a similar look and aspiration, and girls get a similar treatment, or they go to the same injector, and suddenly it becomes a thing.
Yeah.
But when you're removed from out of it or you go into it, it's jarring.
Yeah. Like mullets. Mullets are back.
Well, you know, they've always been the case here, haven't they? With the little sort of scrawny moustache.
Yeah, they went away for a long time, mullets, and then they've just made they're back.
I mean, I'm sure women who move here looking for a date and they see what Aussie guys stereotypically look like, it's weird, right? But, you know, for those guys, it's normal.
Yeah.
So I guess, you know, fashion and taste is obviously microclimates, but I guess what I'm saying is you're influenced by your peers and what you see in social media. And so with all the regulations we've had on social media here in Australia, I do have to say, I think there's something to support that because it does create weird trends that desensitize people.
Yeah, totally.
It makes people think that weird is normal.
Yeah. But the challenge to that as well is like in the digital world, there is no borders.
And AI, you don't even know what's real anymore.
No.
It's
hurting my head.
Wild. Anyway, I think that was a good topic. So thanks, Steve Harris, for the inspiration for that one.
I mean, so what was the conclusion of that? He
doesn't have a conclusion. He what I think's clever about Steve is he just says something.
He throws a hand grenade
and then he leaves it up to the 700 people to comment. Yeah, exactly.
Yeah.
And of course, again, if you're going to follow someone on Instagram, you tend to be supportive of what they're saying, not
of course, in sort of the echo chamber. Yeah,
correct,
to an extent.
But I think it's hard to say that we want people to look weird. Even if you like a more augmented look, you think you look good. You don't think you look weird.
Yeah, that's true.
So interesting one.
It's like other, dudes that go to the gym that like get on steroids and just get bigger and bigger and bigger. Like they keep thinking they're not big enough.
Oh, I saw some of that around the pool. It's interesting.
Yeah.
I mean, I don't know how that world works, but these guys are
they're monstrous. Yeah.
Built like tanks, but then they forgot leg day. They always seem to forget the legs.
Yeah. It's
interesting.
Mm-hmm. Yep.
All right. Moving on to the second major trend of this episode. Now, this is interesting because I don't get it, but here it is. So there was a paper in 2024 entitled Botulinum Toxin Type A Induced Brow Ptosis Reversal Using Bacteriostatic Saline.
So where's this study from?
It was authored by Rullan et al. And as I understand it, Rullan is an injector in the States because I've seen a video of them showing their technique.
Okay. They're a doctor?
It's a clinic. Yeah, it's a doctor.
Okay.
Anyway, so I'll summarize what this paper sort of is, and then we can talk about sort of the conclusions. So over a 6-year period, the authors retrospectively, looked back on patients, and they analyzed 22 patients of theirs who developed a brow ptosis within 1 to 3 weeks following Botox. And I think they used Botox as the toxin.
Right.
To the glabella and forehead. Patients received then 1 to 2 weekly injections of bacteriostatic saline directly into the areas of the lower frontalis and medial corrugator muscles. 21 patients regained the ability to raise their eyebrows within 1 to 2 weeks of the bacteriostatic saline being injected, and the remaining patients showed improvement after 3 weeks. The study also included a small control group where only one side of the frontalis or corrugator was treated with bacteriostatic saline, showing recovery, suggesting the potential therapeutic effect of bacteriostatic saline injections.
Mm-hmm.
So does that make sense? Yes. Basically, they felt heavy after Botox, and then they used bacteriostatic saline injections to, in a way, I don't want to put words in the author's mouth, but flush away the toxin and improve the ptosis.
After how long after treatment?
1 to 2 weeks.
Okay. So, well, let me ask a question. It was my understanding that the toxin is out of the system within 24 to 48 hours. Is that true?
It's a very good question. We always talk about, patient aftercare. Don't do anything for 12 hours. Don't go to the gym. Don't massage your brow, etc. I think realistically, the toxin effect has taken place probably within a few hours, maybe even quicker. So once it's locked in, for want of a better word,
absorbed by, what is it, the nerve or the muscle belly?
Okay, so without getting too bogged down, essentially there's a cascade of events for when the toxin is put into the muscle, and then you get a cleaving of something called SNAP25, and there's a cascade of effect within the cell, and effectively there's a neuromuscular blockade.
Right.
So once you try and move that muscle with your normal acetylcholine, it doesn't work anymore because there's a block in that mechanism.
Right.
And that works over 3 or 4 months, and then the muscle recovers as you get nerve recovery, resprouting of the nerves. So I don't get the main premise to this, that you can just flush away toxin with bacteriostatic saline. It seems very simplistic.
Because the toxin's actually causing a reaction in the body, and then the toxin goes away, it's done its job.
Correct.
So how are you, like, what are you flushing away the toxin, but the toxin's already done what it's supposed to do? I could understand if you did it immediately post injection, maybe, if that would help. I don't know. How does that work once the toxin's already had caused that cascade of reactions?
Well, I have to say that my understanding of the paper is they don't actually suggest flushing away. It's just sort of how it's implied. They actually say that this doesn't work with normal saline, and it doesn't work with water. It only works with preserved saline. So their theory is the benzyl alcohol has some effect. So they're not actually saying it flushes the toxin away. They're saying something with the benzoyl alcohol in preserved saline somehow reverses that toxin effect. Now, they don't go into any more detail. It's just quite a simple case series.
Right.
It's not very in-depth. They don't talk about any science. It's just, I mean, apparently they've been doing this for 14 years. That just in their clinic, they decided one day to try it. And then for the last 6 years, they've gathered 22 patients where they've produced this paper.
22 patients?
Yeah.
Okay.
Now, first of all, I'm going to say that it's always worth looking at science and trying to be open-minded. So I applaud the injectors for trying something different.
Mm-hmm.
Not here to sort of critique them and say, it's complete garbage. I do have some problems with this paper.
Well, I guess the question that comes to my mind is what happens to injectors that are using preserved saline to do their treatments? Does that mean the treatments are not effective?
So this is something that's cropped up in some of our WhatsApps.
Mm.
So as a result of this paper going viral, because by the way, this paper is not new. It's been out about a year, but for whatever reason, it's got some traction and it's been shared in our Patreon, and a few other people suddenly raising the alarm of, should I use bacteriostatic saline full stop, let alone to reverse brow test? I use it exclusively. I've been using it exclusively for years. Basically, because it just makes it less painful, not for any other reason. It's actually more expensive for me, but it makes the patient experience so much better. And hand on heart, it's not just me. Many people have been using bacteriostatic for way longer than I have, and they've never had a problem with their toxin longevity or anything else. So I think we can clearly distinguish, does reconstituting with bacteriostatic saline versus this paper, they're different things. They're not the same thing.
Yeah.
So carry on reconstituting with whatever you like. But this paper suggests that, if you've got a heavy brow, you should basically just do multiple injections of saline if the brow feels a bit heavy. That's the upshot. Now, obviously, you're not an injector, but you know that a week after your toxin or 2 weeks once it's kicked in, it can feel a bit heavy because you can't raise high as you could without toxin. That's just kind of almost normal. And that heavy feeling will probably go away on its own within a week or two anyway, because you get used to it, or it does generally sort of feel a bit better as muscles recruit and so on. So I guess my first sort of critique of this is it could just be a normal effect 1 or 2 weeks after toxin feels heavy. It suddenly doesn't.
Yeah.
So there's no way of distinguishing that from this paper. Two, when you look at the paper, apart from one patient's pre-toxin treated and then bacteriostatic results, there are no other results published. So it's like me stating to you that I've found a cure for cancer without showing you any results.
Yeah, right. Okay.
It's just a statement. Our patients felt better, so it works.
Yeah. Well, that's not super scientific.
It's not really. I mean, look, we shouldn't dismiss patient-reported outcomes are important, There's the placebo effect. There's, just making people feel better. That's all kind of relevant, I guess, especially when it comes to aesthetics, where, some of our data is always less robust. It's more about feelings and emotions as well as actual science. But to state you have reversed brow ptosis with bacteriostatic saline without showing data or photos is a bit difficult to buy into. I'll just leave it at that.
Yeah. No, they didn't do it with eyelids, which is...
No, this is for heavy brows.
But you would assume if the mechanism of action is the same, then you would be able to apply
Very valid point.
You would be able to apply it in different areas of the body, right?
I agree.
Okay.
So,
because that seems to be more of the problem.
They don't comment on that.
Okay.
It's just, they don't say, well, this could be used elsewhere. That's our next study or whatever. That's not commented on.
What was the purpose of the study?
Well, essentially to show that their technique of reversing ptosis, I guess, works or is an interesting thing that you might want to try. Now, I'm actually supportive of the fact that why not try something that is relatively non-invasive? It's a few injections. Yeah. It seemingly has no harm. It's more bacteriostatic saline. And if your patients feel better, whether it worked or not is a different thing. But if you're trying to do something to help someone and they say, I feel better, who am I to judge?
Yeah.
But, I think we need to talk about science versus, just placebo effect here.
Well, the issue is these things, as in this case, go viral and then it starts to open up a whole can of worms.
That's my issue.
Yeah.
That's my issue. It's people now questioning their whole reality of, should I reconstitute with bacteriostatic saline because I'm worried about longevity? Is it going to make it last less?
Mm-hmm.
It's injectors not understanding the science or not understanding how to read a paper or just being scared by noise and suddenly changing their whole practice based on what is not a very robust study. That's my issue with this. I just want to talk about one thing because I thought it was kind of funny. So in the one patient's results, if you like, that they showed. So in picture one, they showed them raising their eyebrows before Botox, and you can see some wrinkles, and obviously the brows go higher. Then they show the post-Botox result, less wrinkles, and the brows are a little bit lower. And then they do this injection of bacteriostatic saline on one side of frontalis. So you see like these big boluses of bacteriostatic saline on one side of the forehead. And then I think a week after that, they show that that side has got some apparent wrinkles, and therefore they have, I'm using my word here, flushed away the toxin, and it's got some movement back. But interestingly, the brow is still low on that side. So they haven't actually improved toxin-induced ptosis. And on the non-treated side, the brow is higher.
Right.
So they're saying that we've treated brow ptosis with bacteriostatic saline, yet the picture doesn't show it.
Right.
So even the one example that they chose doesn't show what they are stating. So anyway, I'm not here to knock authors trying to show new science or something interesting. I just don't get it. The other thing that's interesting, and I think this is just relevant for injectors just planning toxin, they said that their typical treatment for all of these patients was 15 units in the glabella and around 10 for frontalis. So you're not an injector, but what do you think of injection of roughly 15 in the glabella? Is that low or is that high?
Low.
Yeah, it's low. If your baseline was around 20 or the equivalent for another brand, you might have actually created a ptosis by undertreating glabella or suboptimally treated your patient. And then if you do treat frontalis with 10,
which is standard, isn't it? Or 10, 12.
I don't know what standard is anymore, but if you're undertreating the depressors and treating frontalis, you might create brow ptosis full stop.
Yeah, exactly.
So it's just the technique itself might be creating this problem, and the bacteriostatic saline has got nothing to do with it.
Yeah.
And you would know that a week or two after any treatment, it just feels more natural and that heaviness lifts itself.
You acclimate to it and
Yeah. So I don't know.
But yeah, it's more the whirlwind of activity it's caused online and people, as you said, freaking out, wanting to change their practice. And it's just this Chinese whispers kind of thing.
And this is sort of where the podcast came from or evolved from. We didn't want to have these conversations on social media.
Yeah.
We've got a disclaimer in our podcast. Please don't listen if you're a patient. This is for practitioners to understand and discuss, and we get experts on normally. So we're trying to have these conversations away from the public sphere because of this drama that gets created that is unnecessary.
Yeah.
So,
has there been much pushback to this?
It's interesting. I was very sort of black and white with colleagues saying, I don't understand this. And some people said, oh, I don't know, might be something there. I just don't really understand it yet. But I mean, me sort of just very quickly critiquing this, I actually did this morning. I just can't find anything that makes sense. So yeah, just as an injector, I guess we're actually going to try and get an expert on to talk about how to critique a paper and how to understand science, because it's so important. I'm not amazed that this is published. I mean, I think everything has some relevance, but it's a very low quality, small sample, retrospective, not randomized. There's many things that make this what we call low evidence, low level of evidence. And yet, if you're an inexperienced injector and you just read this, you might go, oh my God, this is a major revelation. And I just think you've got to be careful with, just because something is published doesn't mean it's real.
Yeah.
It means you need to go with a fine-tooth comb and actually understand the science.
Yeah, you raise a good point. I mean, I think that increasing the average injector's awareness around how to critique studies, how to sort of critically think about these things is probably what's needed the most, because people tend to whip themselves up into a frenzy. They see enough of these conversations happening online, and it just starts to become this almost like a like a phenomenon just based on the level of activity that's going around the particular topic. It just becomes a major issue. It's disruptive, and no one's actually gone back to first principles thinking and sort of looked at it from a scientific perspective.
Yeah. And I would guess, just to say again, that if the psychological impact of the patient is, wow, that feels better.
Mm-hmm.
Again, who am I to say that that's not a good thing, that you're trying to help your patient? But, we touched on this in episode 300 with Michael and Jean. There are companies developing actual antidotes to toxin.
Mm-hmm.
That makes sense to me. If you can somehow uncleave or sort of reverse the actual pharmacokinetics of the toxin effect, then cool. If we could have a high lays to toxin, that'd be fantastic, rather than messing around with stuff that doesn't seem to have any science.
Yeah.
But anyway, I'm here to be challenged. If someone doesn't agree with what I've said and or you're the author and you want to come on, we're happy to have a chat about this.
Sure.
I just don't get it.
Yeah. Well, that's just the industry, isn't it? There's new stories coming up every day.
Yeah.
Yeah.
Now, what's going on in the business world? Just to, I guess, conclude this episode. I mean, I guess the major trend that you or we are seeing in Australia is consolidation, and because of all the regulatory change and people maybe having to change their sort of models and so on. What are sort of some of the solutions, or what are people thinking right now?
Depends on who you talk to. I mean, there are some people that it's traveling along seemingly unaffected by all these things. More of, I guess, the doctors that are self-sufficient, that don't require scripting, they don't have the extra costs to their businesses. There's a lot of fear around where the regulations are going to go and what does that mean for their business in the long term, because is this solution that seems to be what all these companies are proposing at the moment in terms of how they're going to get it, not get around, but comply with the laws in terms of doctor coverage and, dispensing of S4 medications. Is this the end of the regulation, or is it going to be more? Is this solution going to be challenged at some point? Are we sort of going to get to an inevitable outcome where, it starts to become impractical for people to have their own businesses and sort of work independently, because the regulators are being driven by a perception that there's a major public, health or safety concern. They do raise some very valid points around, how these medications are handled and dispensed.
Well, I will say that this is not just an Australian issue. It's happening in the UK and America in various states. So this is like a global thing where regulators are making people's businesses having to think about, can we survive as we are?
Yeah.
So it's not just an Aussie problem. Yeah. But
yeah. So, we've got the regulations, we've got the consolidation, all these things I've spoken about before. So I'm sorry if I'm repeating myself and people are thinking, keep saying the same thing, but it takes a long time for the message sometimes to sink in for people, that they actually need to start looking at their businesses at a deeper level and going beyond just what they clinically do, and thinking about the future of how you look at de-risking your business. So how do you consolidate? I was talking to a client a few days ago, got a great business, making great money, solo nurse injector. And we're having the conversation around, well, how do you de-risk your business moving into the future? And, we're throwing around ideas about how do you consolidate your practice in with a doctor potentially, and sort of being able to future-proof your business where you've actually got a doctor on site. There's, how do you commercially come up with some kind of a deal that still means that you're able to sustain yourself financially and provide for your family, but still make it a no-brainer or attractive enough for a doctor to say, yeah, I'd like to bring you into my practice. You've got all these patients. What's the commercial sort of reality of what this partnership or this union could look like to future-proof your business? Because I think that's the strongest skill set that a business owner can have, is being able to mitigate risk and sort of think a few moves ahead. And I think if you look at what's going on in the regulatory world, it seems like, this is not the end of where these regulations are going to go. I could be wrong, but if I was a business owner now, I'd be definitely thinking about, what happens 6 months, 12 months, 18 months from now. Are these solutions going to be challenged? If so, what does that mean? So that's what I'd be thinking about. And again, people who are going to start to have to maybe give up a share of their business or a share of their revenue, having enough business acumen and financial knowledge to be able to start making decisions around, okay, well, I don't have if I consolidate and I move in, with a other group of nurses and we've got a doctor on site, or I consolidate and move into a doctor's premises, or whatever the case may be. What does my business look like if I remove these fixed costs? What does it look like if I have to give away a percentage of my revenue or my profit? How do I sort of make these assessments? Just being more comfortable with the numbers. But as I said, the majority of people aren't familiar with their numbers. And so it makes it difficult to be sensible with your decision making. Some clients that I talk to and they want me to have a look at their business, or they've got an issue operationally with their practice, I always start with, let's have a look at the finances. And a lot of people don't understand why I start there. They might say, well, I've hired you because I want you to help me with an operational challenge, but for me, that's like that start, like when a patient comes in to your clinic, if they come in with an ailment or a complaint, you're still going to do your basic health assessment. You're going to look at their blood pressure, their heart rate, their oxygen sats, blood work if needed. So even though the patient's complaining about X, you're still going to do your due diligence to say, let's look at the overall health of this patient. And it's the same with the practice. So a lot of people don't understand why I start there. And the reason is because I want to get a pulse read on the health of your business, because inevitably everything that we discuss around growth, marketing, hiring staff, buying a device, selling a device, expanding your route, anything that's decision-based, involving a decision with your business, you're always going to have a look at what is the financial impact potentially of making that decision. And unless you know those numbers, then you might be making decisions that could hurt your business financially. You might be going backwards. So, as much as people don't want to potentially go into this area of their practice that they're not comfortable with, people that resist that and don't get their head around it will probably pay the prices at some point. Yeah. Not everyone. Some people are making so much money, they've got such deep databases of patients, their margins are so great, they'll be unaffected. But there will be a lot of people that sort of drag the chain on not getting up to speed with this, and it's going to be an issue for them. So
I guess to summarize this trend, for the millionth time on this podcast, it's people kind of being resistant or not understanding their numbers, and yet the market is changing.
Yeah. And they're going to get caught with it.
You need to know.
You're going to get caught with your pants down at some point, because you'll wake up one day and the margins won't be there anymore, or you'll have to make a decision that's going to increase the cost base of your business.
Yeah.
And you may not be able to afford to do it, or you don't understand or realize the impact it's going to have on your practice. And I know it's scary for people, and I know that people, even when you and I have these conversations, I can see you glazing over sometimes, because it's an area that you're not comfortable with. Just like if you started hitting me with like all the scientific information in a paper, I'd probably glaze over as well.
Yeah.
It's not my area of expertise.
Yeah.
But you don't need to become a chartered accountant. You don't need to become a financial analyst or wizard to get to grips with the basics. And I think I'm going to do some more Patreon content on this. And I've got a few friends of mine who are saying you need to actually record like a series of educational videos to really break it down for people. But I gave a talk not long ago for the CNA. It was on business, so the Cosmetic Nurses Association here in Australia. And I've posted that webinar in our Patreon for any of those of you that haven't listened to it yet. And it was business essentials for 2025. And I've just broken it down into like 4 things. If you're someone that's completely financially illiterate and you just need to get your head around 4 concepts, how to just basically interpret a profit and loss statement, understanding what your balance sheet means, understanding what your margins are on all the products and services that you sell within your business. And I've actually included a spreadsheet that I created that you can download, and you can just plug in, you sell Botox for X, you buy it for Y, you have this much money that you spend on your dressing packs and your consumables. This is how much profit you're making. This is what your margin is. It couldn't be simpler than that.
Yeah.
So just going through that exercise and working out what your margins are, and then how much money does your business need to make to stay open every week. If you can just get your head around those 4 concepts, and most of these things I can teach people within like 1 to 2 sessions.
Yeah. And
then it's just getting into the habit of like looking at these things. And it's like everything. The more you do it, the more familiar you become with it, the easier it becomes. But that's my message, is like, just, take the time. And if it's not me, if it's another business coach, if it's your accountant that's happy to take the time to teach it to you, just start to get your head around these things. Because if you need to start making decisions to pivot your business in a different direction, or you've got a cost base that's increasing, having this knowledge will empower you to make more sensible decisions.
We'll put a link at the bottom of the podcast description that goes straight to that post. Now, yes, you'll still need to sign up to Patreon, but at least you know where to find that.
Well, we've got a free trial.
We do have a free trial.
Yeah.
So check it out.
Yeah. If you want to be really mean, you can just come and download it, then cancel. We'd obviously not like you to do that and join and support us. But if you're sitting on the fence about whether you want to check out what it is that we do, there is an opportunity to sign up and have a look at the content, because I think, now's the time.
You just reminded me to finish this podcast of an event that happened on the plane to Dubai.
Oh, here we go. Yeah.
It hasn't happened in years, but I got that call. Is there a doctor on the plane?
Oh, really?
Yeah. Well, when I say I got the call, it happened like 3 seats to the side of me. Basically, I think what happened was there was quite a big guy that had too many drinks. And I only got this history, but basically he was sort of unconscious, let's call him unconscious, but breathing. Right. And just sort of, slumped over in his chair, sort of
snoring,
exactly. And the woman next to him was sort of trying to push him off her because he was just sort of slumped on her. And there's a big sort of kerfuffle. And then my wife, who was basically sat next to him, goes, "He's a doctor." And so I sort of, obviously got involved and jumped over. And obviously the first thing I did was, is he breathing? Do we have an oxygen sac probe? Tried to get a blood pressure, heart rate, all the rest of it. Essentially, he's breathing and got a pulse, so there's nothing else I can do.
Yeah.
The only thing we could do is attach some oxygen, so he was on the oxygen, and just sort of kept him upright because he was snoring quite badly. So you can
sleep apnea. Yeah.
Sort of. Yeah, exactly. You can sort of choke off your airway if you can't support your head.
Yeah, especially if you're a bigger person.
Exactly.
An issue.
But yeah, it was kind of. I'm glad it wasn't worse than that, because you feel very vulnerable on a plane, and very vulnerable as an aesthetic doctor who doesn't really practice, hospital medicine anymore.
Yeah, interesting.
So that was interesting. And
was it from Dubai to Sydney?
From Sydney to Dubai.
Oh, on the way there, right?
Yeah.
Okay.
And apparently, having just asked the people around him, he was having like 5 or 6 shots an hour for the whole flight, which is a 14-hour flight.
How would the that comes back to like, what were the air hostesses doing?
We actually complained and said to the head of the stewardesses, we were like, this is not normal behavior just to keep on supplying someone until they're unconscious.
I had a similar situation where, well, obviously I'm not a doctor, so no one called me for help, but there was a guy that was flying to, I think it was to Dubai as well. And he drank so much that he actually like weed his bed. They had to like wake him up, and there was like just urine everywhere. He just weed himself. As soon as he got on the plane, the drink started coming.
Yeah.
And he urinated everywhere, and it stunk, and it was horrific.
Yeah.
Yeah. Anyway.
That was not good. Anyway, that's the end of today's podcast. On a happy, cheery note.
Yeah.
Don't drink too much on a plane.
Yeah.
Anyway, hopefully you guys enjoy the impending evolution of the podcast.
Yeah.
We will be producing more and more content soon. There may still be another week or 2 where there's a gap, unfortunately, just because of our various travels and so on, but we'll be back up to speed soon.
Yeah. Thanks, guys, again for all your support. All of those in our Patreon community, special thanks to you for, I guess, helping us continue this crazy operation or this crazy project that we've been doing for the last 6.5 years. And stay tuned. Big things to come.
Speak soon, guys. For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloane and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.